When considering end-of-life care, we need to focus on desired outcomes, the need and preferences of our patients as well as their family. We need to think about what those needs and preferences are. Also, though, you need to consider, are those ideas realistic? So do they have realistic expectations and goals? And are those goals going to be able to be met? So the goals really need to focus around control of the symptoms of distress. So controlling the shortness of breath, controlling pain, controlling the environment, helping with spirituality, involving all of those people in the patient's care team. When you are thinking about the patient, you can see by this pictorial view up here, the patient really needs to be the center, but also we need to include the family as part of that team. So not only is it patient, but also family, and then nursing, social services, physicians, spiritual care, and ancillary staff and services as needed. So all of those interventions that we are going to choose need to meet our patients' physiological, social, physical, and spiritual needs. Again, just to reiterate one more time, with peaceful death, we want to focus on quality of life during end-of-life care and not helping them die. So your goals need to be realistic, but also to the point that how can we make them comfortable? How can we make that a peaceful death? It's very dimensional, as you can see by the illustration, by everything that I've talked about, that lots of things need to go into the consideration of end-of-life care and desired outcomes. So this slide just talks a little bit about the different approaches and different philosophies behind hospice care and palliative care. Actually, they are very similar. The palliative care can be started before hospice care. Typically, the thing that's differing with hospice care is that Medicare and insurance companies require the patient to have a prognosis of less than 6 months and are no longer seeking treatment for their terminal illness. So that's kind of the difference with hospice, because palliative care, we want to meet those goals and we want to achieve the best quality of life for patients and treat symptoms of the disease, but they're still able to be seeking out treatment for the disease process that is going on. So we can actually start palliative care much earlier than what we can start hospice care. So with the patient-centered care, we need to assess symptoms of distress, so symptoms related to pain and discomfort, because those are going to be the most distressing symptoms for the patient and the family. As I said earlier in lecture, that is a patient's number one fear, is dying in pain. So we want to keep them comfortable. We also want the family to know what the goals of our patients are so that we're all on the same page. For management of pain, we're going to be looking toward long-acting opioids. Remember to use the best route available. So if they don't have IV access, then you need to think about rectal, or you need to think about topical. If you are using a long-acting opioid such as your MS-Contins, remember we can't crush those and we can't chew those because those are going to be sustained release. Complementary alternative methods are going to be very good to use in conjunction with opioids. So the use of massage, music therapy, therapeutic touch, aromatherapy, lots of those different types of things. We need to think about decreasing opioid doses as the patient gets closer to the end of life when they're in that active dying phase, because we don't want to overdose them. And once the patient has oliguria or anuria, you can consider or be cognizant of the possibility that delirium can occur due to the high doses of opioids. It's really not a current standard of care to decrease those dosages because we do want the patient to be comfortable. But if you are seeing that patient that is in the active phase of dying, having some deliriums, it could be an opioid overdose. So don't just rule that out. The physical assessment and clinical manifestations, we discussed those a few slides back, but think about weakness, drowsiness, unresponsiveness, decreasing speaking capabilities, so watch for their nonverbal cues such as restlessness, agitation, grimacing, moaning, anything else that you can think of as far as your nonverbal cues. With the psychosocial assessment, coping, fear, anxiety, anxiety about impending death and dying, different cultural considerations, their values, their beliefs, what the family influences are. So the psychosocial is really a huge part of end-of-life care. For weakness management, they will need to be on aspiration precautions, and for families to watch their patients stop eating or watch their loved ones stop eating, that can be very difficult, because oftentimes we feel like if someone is still eating and drinking, it's somehow going to make them better. But we do need to reinforce and provide education about that to our families because of the precautions and the possibility of aspirations. So we need to stop oral routes of medication, oral routes of fluids, medications when the patient is no longer able to swallow or they become very lethargic. Provide oral cares, making sure that you are providing moisture for the lips, an alternate route of medications. So if they don't have an IV or they don't have a port, consider the rectal or topical routes. And also, as the active phase of dying increases, we will see decreased in neurologic functionings, which also makes them have a decreased capability of swallowing. So even the GI secretions, if they have nausea and vomiting, those types of things are going to be things we need to be concerned about. Treatment of dyspnea, as far as pharmacologic management, the things that we need to use to treat dyspnea, you can see that opioids is listed out up here, and opioids we typically see used for pain, but they're very useful in the treatment of dyspnea. They have an inhaled opioid that's called Roxanol, and Roxanol works really wonderfully to give in a nebulizer to help those folks with end-stage, end-of-life care, active dying that have dyspnea or shortness of breath. Anticholinergics to help dry up secretions. A lot of times you will see physicians prescribing atropine drops, and so just putting some of those drops in about every hour can help dry up those secretions and help decrease that death rattle sound. Bronchodilators to open airways, so your albuterol nebulizers, Xopenex, just kind of depend on what your physicians, what their preference are. Sedatives to help with sleep and rest, to encourage them to rest. And the corticosteroids will help with spasms of the upper airways. So thinking about if you have an IV route, you could use Solumedrol, betamethasone, dexamethasone, those types of things, and then oxygen therapy. When I want to caution you about oxygen therapy, because oxygen can provide life-sustaining measures. So when you think about oxygen therapy, think about what's going to be comfortable for the patient. So if a nasal cannula is more comfortable, then we need to focus on the nasal cannula. And remember, we can only use nasal cannula up to 6 liters. So just be aware, we can use oxygen therapy for replacement, just to use it per comfort. Diuretics for fluid volume overload, so your Lasix, spironolactone, aldactone, Bumex, lots of different things. And then antibiotics for infection. So when you're thinking about dyspnea, it can be directly related to their primary diagnosis. So maybe they have a diagnosis of end-stage COPD or pleural effusions. It could also be related to lung or breast cancer, coronary artery disease. So lots of different things. Or it can be obstructive. So maybe there's some type of vascular disturbance, or we have congestion from fluid volume overload because kidneys are starting to shut down. Low hemoglobin, maybe some anemia going on. We don't have that oxygen carrying capability. So lots of different things are going to be associated with dyspnea. With nausea and vomiting management, the antiemetics are listed out up here. Nausea and vomiting really occurs frequently with end-of-life care, especially our patients with AIDS, breast cancer, stomach, or any of the gynecologic cancers. So we also see nausea and vomiting due to uremia or increased serum urine nitrogen, hypercalcemia. We can see it due to constipation, impaction, obstruction, increased intracranial pressure. So lots of different things to think about. So always want to get to the root cause of what that nausea is coming from. Why are they nauseated? Are they impacted? If they are, what can we do to help relieve that? It's always a good idea to not bring a lot of odors, so food, perfumes, those types of things. Keeping that room kind of cool, not on the warm side. And then the complementary alternative methods, peppermint, chamomile, and lavender are very good essential oils that can help decrease nausea and vomiting. So a few different things to think about when you're considering those patients. Treatment for restlessness and agitation, again, going to that root cause, finding out what's wrong. Are they impacted? Are they retaining urine because of the use of the pain medications? So assess for pain and urinary retention or any other reversible cause. And then if that doesn't work, then you can look for a pharmacologic agent such as Haldol or Paradol. Keeping the environment calm and reducing the noise. And oftentimes the patient will respond to just those things, and we don't have to look toward Haldol, but just be aware that it is out there and you may see it being used. So psychosocial management and the nurse's roles. So as you consider your role as a nurse, think about Kubler-Ross and her 5 stages of death and dying. So think about what the patient is going through, and with the denial and anger, always remember that you are probably going to be a target of anger at some point, because these patients are going to be angry in the beginning before they are able to accept it. So be very aware that we may be the target for that anger. Try to keep the family and the patient involved in healthcare decisions, and be aware of where they may be at as far as the stages of death and dying. So response to death and loss, it's going to be dependent on what the loss is. So I've listed several reasons for loss, not necessarily death, but also loss, because loss does carry a component of grief with it. And so you have to be aware that it's not always going to be a death that is going to cause grief. It could just be loss. Thinking about cultural aspects, European Americans or white Caucasians have a more positive attitude toward death versus other cultural populations, because the other populations really focus on the family and being family-centered. So there can be difficulties when you are considering the cultural aspects. With nurses, just remember to take care of yourself. Know that it is okay to cry with your patients. And if you have a traumatic death, make sure that you go to those debriefings and you talk about it, and you get that out and in the open so that you're not hurting yourself. With euthanasia, euthanasia is withdrawing or withholding life-sustaining therapy. So in your book, it talks about passive or an active euthanasia. So I would ask you to take a minute and stop and look those up. Active euthanasia is where your healthcare provider will prescribe a medication that will, with the intent of helping that patient to die, and that is illegal except for in Oregon, Washington, and I believe there's one other state right now. But we as nurses stand together as a force, and the American Nurses Association is strongly against active euthanasia. And lastly, post-mortem care. You need to think about legal considerations. So we do have to have a death certificate. You do have to notify your physician. I would take a look at chart 9.5. It does explain signs that death has occurred. And if death is at home and is expected, there's really no reason to call emergency medical services. Typically just call the hospice nurse or the home care nurse. And then the nurse will call the funeral homes. Determination of need for autopsy. If it is an expected death, really autopsies aren't done. But if it's some type of traumatic event or we're unsure of reason for death, then we can see that autopsies will need to be done. If the patient has an autopsy and you have been working on that patient, leave all tubes and drains in place. Allow the family time to say goodbye, bathe the patient, prep them per their normal custom and rituals. And so I would ask that you take a look at some of those cultural differences when you are considering post-mortem care. Typically, it's elevate the head of the bed about 45 degrees, put a pillow under their head, replace dentures, and then document everything that you send with that patient to the funeral home with a mortician. If you have any additional questions, please don't hesitate to send me an email or stop by my office. Thanks so much.